behavior change in patients with persistent pain for all of us, not just when they come to physical therapy, but as pain providers as well in primary care and other specialties, and to recognize the demand for effective communication to multiple disciplines, as a seat at the table of this dream team of providers involved in the patient's care plan, and to employ effective communication regarding pain behaviors to other providers as part of the dream team and to our patients as well. So for introductions, I am the second name on this actually. I'm not sure why the last two got pulled and Brendan didn't, but Brendan's really important too. This is Brendan McGreevy. He's a physical therapist in the Spine Wellness Center in Westport, Connecticut, and a member of the Spine Program Council for HHCRM. I am James Smith, the second name, the first golden one, and I'm the clinical lead physical therapist in the Norwich Clinic at the MCC, and I'm also on the Spine Program Council. And then this is Dayle Stark, who's our fearless leader on the Spine Program Council. She's a physical therapist in the Stores Clinic, and she is the Rehab Network Spine Clinical Program Manager. So we're honored to have this team to talk to you guys today. So setting the stage, like everybody's already said, so this almost seems like a boilerplate at this point, but like we know there's a lot of patients with chronic pain, with persistent pain. I get the numbers in the US, generally like 25% of the population. So we have a lot of people that really need help. And then a very interesting study came out of JAMA this year. It was a systematic review meta-analysis, and it demonstrated that close to 40% of these individuals exhibit symptoms of depression, which is not a surprise to me, because I've worked with these patients as well. And greater than 40% of them experience clinical symptoms of anxiety. So clearly there's an indication here that there might be a different target for us to approach as well to help these patients. And so, here's kind of a fun slide. I didn't just put this crazy array up here to make it look confusing, but it kind of looks like the array that the first panel put up when we talk about all the things that affect the patient's outcome, but it's just a lot more complicated. So when we talk about managing these patients, or any patients, we always talk about the biopsychosocial model. But as we're kind of finding out, like it tends to be like a small amount of bio, and it's like a mounting or growing amount of psychosocial. So psychological factors are largely more effective at predicting persistent pain than pathognomonic, like we were studying those. So when we look at this array here, I took this from a Viewpoint article in the Journal of Orthopedic and Sports Physical Therapy. It was about biomechanics, but it was sort of trying to decide that would knowing more about biomechanics help us manage our patients with persistent low back pain better. And then it took this graph, or this graphic here, from a panel of spine experts around 2022. It was a multimodal team that got together to come up with a list of all the things that they perceive affect our patients' outcomes. And some of this is tissue injury or pathology. That's the yellow. Does this work? It does work. That's the yellow group down there. And some of this is biomechanical factors. But if you look at the totality of this, it's a lot of other stuff, right? Like psychological factors, individual factors, the patient's age, stuff like that, their genetics, nociception detection and processing. And then contextual factors, like what's going on around the patient, their behavior and their lifestyle, and also social and work factors. And if we just address the pathoanatomy or just the biomechanics as physical therapists, we're definitely going to miss the forest from the trees. So we want to make sure that we don't do that. We want to also ensure that we're focusing on the right target. You guys in the panel talked, thank you for laughing. In the first panel, you guys talked a little bit about like getting the buy-in, like meeting the patient where they're at. Like we don't want to be taking our patients to target when they want to do like archery or something like that. So I think I actually had a pretty good story about this. Funny thing was yesterday in the clinic, so we're always learning about it. I told a patient with like persistent back pain, she's sort of a stenotic patient, she's a bit older, uses a walker, she's had many different procedures and surgeries, she's like in her 70s, she's like, what are you doing this weekend? I was like, oh, we're actually talking at, this is kind of perfect, we're actually talking at this pain management symposium. She's like, oh, what are you guys going to talk about? And I was like, behavior change. And she's like, oh, what behaviors of mine are you going to change? And so I thought that was really funny and also like convicting, because we have been working on, she's stenotic, so she has a limitation in lumbar extension. Her hips are a little bit inflexible, so we're working on that, working on a little bit of gait. And she's like, my real problem, like it's nice that we're working on like walking easier, getting stronger, getting more flexible. The real problem is I just want to be able to go outside and walk around. Like I'm super depressed that every time I open the door, I feel that I'm in too much pain to actually go out there and enjoy it. So she's like, how are we going to address that? So that's actually what we're going to talk a little bit more about today when we get into the second section. And this is just what we have to offer as physical therapists. I'm older than this, but as part of the multimodal team, like we're really evidence-based personal care for these patients. More and more, like the guidelines are indicating that they want us to try conservative stuff first. And Dr. Reese indicated, like Insurance oftentimes, most of the time, requires at least 6 weeks of physical therapy, but we can offer a lot more than that. Like, it actually is helpful too. So we provide education to these patients to work with all these factors that they have and figure out how we can make them move. And sometimes that also relies on our pain points as well. And so we're also addressing those biopsychosocial factors that drive disability. Our goal is to really challenge some of the harmful beliefs that our patients have about pain. It really is okay for them to be able to move and to make them move so they can have early activation and return to function. And like this discussion of like mounting pressure from payers and insurance, like really our goal at the end of the plan of care isn't always like getting rid of all their pain. We know that like a lot of times that is not possible. Like you're going to have another episode again or it's going to persist. We want to make sure that they can do self-management. So we're teaching them how to manage these symptoms independently. And we're also doing appropriate screening to identify red flags and make appropriate referrals to you all. So now I'm going to hand off to the floor to Brendan to talk a bit more about the behavior change piece.
Thank you, Jake. Appreciate you warming up the crowd for me. That's great, thank you. So, hello everyone again, my name is Brendan McGreevy. I work at the Spine Wellness Center over in Westport as a physical therapist. And as a physical therapist, my hopes are to get individuals back to their quality of life through improving their confidence and their self-agency, as we spoke on a bit earlier today. So in the folders in front of all of you, there's a handout that goes a little bit more in depth into some of the core aspects of our presentation, as well as a little bit more depth on the case study that I'm going to present and behavioral terminology that we often associate in these chronic pain patients. So where I'm going to begin is I'm going to begin with imaging. Imaging because while it is an essential tool, it doesn't quite define the whole clinical picture for the patients we see. And in fact, I often see this as an opportunity around the discussion of such results as moments to help reframe how patients interpret what's on the scan and to reduce the unintended impact of the words we use to describe it. So because what patients carry forward isn't necessarily just that image in and of itself, but also the meaning that they attach to it, and that's very important to keep in mind. Multiple meta-analyses have demonstrated for us that the same findings that we see in people with pain, whether it be degenerative changes, discogenic changes, things like rotator cuff tears as well, we'll also see these in folks who are pain-free and across the lifespan. So we know that, again, as Jake mentioned, that the mechanical factors aren't the full story for these patients. And the words that we use, again, to describe these findings often and very much matter. Often these patients, again, they don't take this as just some like neutral finding or perhaps the way that we mean to come across when we give them our medical jargon, but they often hear these as predictions of their future selves, and that can really create a problem in the chronic pain individual. So again, our role is to complete that message and say, yes, this is what we see. However, this doesn't define your potential for improvement or your ability to function and live well. And that's a super important message, I think, that we all should instill in our patients from day one. So, why motivation fails and fear avoidance loop. So when pain emerges, that's a direct nervous system threat. Stopping the activity that stops that threat feels protective in that moment, but then in the long term, what this leads to is, as we know, loss of identity, loss of function, deconditioning, has a huge emotional and cognitive toll as well. All these things we know perpetuate the pain cycle, as we saw in that massive diagram with everything that is involved in this pain space. Over time, avoidance often accelerates this decline we see in patients in their life, a cycle we recognize as the pain avoidance model. Fear often leading to withdrawal from activity, which leads to deconditioning, hypervigilance, increased pain sensitivity, and then overall greater disability, and so on and so on. All in all, it's not that these patients are unmotivated to make the changes that it takes long term to modulate their pain, to get their lives back on track. It's that their systems are literally in conflict with one another. On one hand, they're looking towards I want to live my life. I want to be the person who I once was. And on the other hand, I don't want to continue to cause structural damage or experience more pain. And so essentially for them, it's like trying to move left and right at the same time, and no movement happens. So the question then becomes, how do we as clinicians help patients resolve said conflict? And that's where a few key motivational tools can really make a difference for them. So a few of these tools that we can use alongside our plan of care are just a couple of communication strategies that we derive from different aspects of psychology. So the COMT approach is derived from health psychology and helps us map out whether it's capability, opportunity, or motivation that is the primary block or a mix thereof of getting the patient to their desired behavior changes. ACT, or acceptance and commitment therapy, is well supported in the chronic pain literature at this point, and it shifts the control from necessarily controlling pain to more of a psychological flexibility approach and maintaining the patient's values as the core construct. Everyone at this point has heard about motivational interviewing, very, very popular across all sorts of disciplines. Its origins originally came about within addiction medicine, actually, and in the chronic pain sphere, what we can use it for is to help draw out the ambivalence and build change talk rather than pushing patients into something they may not be ready for themselves. And then, of course, simple language changes to swap in during our clinical visits with patients, things along the lines of, let's see if this hurts, is this painful, versus let's explore the possibilities, despite this pain being present. And these aren't only PT tools, anyone can use these, but I feel like as physical therapists, the integration of movement, pacing strategies, and physical activity is such a unique opportunity to build that traction in this chronic pain space. And so to kind of see how this plays out, this is where I'm going to present our case, and this is a woman that I saw some years in the past. So we're going to call her Taylor to commemorate T Swift's recent album drop yesterday. Thank you again for the laugh. So Taylor's a 66-year-old woman, and in her history, she had spent in her younger years 2 to 3 decades as a competitive figure athlete or physique model. Later on in life, she experienced a T11 compression fracture, and beyond that, ended up having a lumbar spinal fusion. During these same times where she was experiencing pain pre and post-op, she was also caring for her husband, who was battling cancer and then ultimately passed away within a short time frame from her post-op recovery. During this time, she was struggling quite a bit. Her family in Connecticut helped pack her up from the Carolinas where she lived to bring her up here. So as this time period kind of perpetuated, her depression really wove into her well-being and part of her identity. So this may seem like an odd question at first, but if I may, how many of you have ever been a physique athlete or a figure model? Anybody? No one? So I think that's an important question because I wanted to get to some of this woman's depth. So this was a woman who had decades of experience of pushing herself physically, experiencing the harsh exposure to dieting during this, and getting on stage in front of hundreds of individuals in her skivvies, with some coaching, of course, to help guide her. But this new experience of chronic pain, depression, just this whole uprooting of her livelihood, she didn't have a coach for this. She didn't have any guidance. And so she succumbed to her condition. And what this looked like for her, so when I ended up meeting her, this looked like the house that she moved into. Her family helped her install a ramp to get into the few steps into her entryway. Everything that she owned was put on the first floor of the house, so she closed herself off from the second floor. Everything that would traditionally go into our cabinetry, she placed on the countertop itself to avoid any sort of overhead lifting, to avoid extension, because God forbid she fractures another thoracic spine vertebrae. And she did all sorts of things along this nature, along with avoiding going out even, which involves lack of social interactions, lack of time with her family. And we can see how this would cycle into more depression, more anxiety, so on and so forth, and perpetuate this chronic pain cycle. Now, one of her major driving factors I came to find was this daily mantra that she shared with herself that she garnered from a provider that she had had in the past along her care journey. And this message was that if she wasn't careful, she'd be wearing her ribs on her pelvis, meaning that her spine was so fragile that any sort of slip off a curb and wrong step would lead to, for her, visually seeing her ribs on her pelvis. Now, I can't imagine what it must be like to repeat that mantra in your head for years and years and years. So we can kind of see where this would perpetuate huge behavior changes. So what were intended as short-term movement precautions and perhaps a cheeky remark by a previous provider, this really became her identity for this patient. So she lived in this constant storm of hypervigilance, anticipatory anxiety, rumination, and a suffocating sense of fragility and withdrawal. Withdrawal not just from her family and activity, but also from who she was as an identity, as an individual, So in our sessions, how did we begin to help her step away out of the storm? And I say we as we lean into this next portion of the presentation because it was super important to establish a team sort of effort here to make sure that she knows that she had a guiding hand alongside with her so that we could then help propel her into more self-agency and independence. So resolving the conflict or some of the interventions we did beyond some of the typical physical therapy things we're all aware of. So first we can go back to those conflict resolution tools that I talked about, COMT. So for this individual, her capability had declined from years of decreased activity, years of social withdrawal, and this led to deconditioning and a lot of protective posturing in one way or another. Her opportunities to move and engage were very limited, both physically by her environment and emotionally and cognitively out of fear. And her motivation was split, again, from this deep wanting to live her life fully and this battle of not wanting to experience her spine go through further degenerative change and also the pain that she had been experiencing. So mapping that out gave us a nice shared starting point to figure out, where do we need to start this journey with her in our physical therapy? So moving on, we drew from some of the acceptance and commitment therapy framework to help reframe her relationship with pain. So instead of, again, chasing pain control, we focused on some of the more psychological flexibility constructs with this paradigm of thinking. So identified her personal values, what she wants to get back to, her goals, for instance, like being present with her grandchildren and feeling independent again, and returning to being that strong, athletic woman that she knows she had inside of her. So our conversations started to naturally shift over the months that we worked together from how do we make this pain stop to what's worth doing even if it's uncomfortable, and this does take time. So through motivational interviewing, we learned to lean into her ambivalence, that tug of war between facing that part of me that wants to avoid pain, that part of me that wants to live a full, healthy life. So facing those parts of her that were terrified to move and terrified to wither away, and the other parts that missed who she used to be. And by reflecting on both of these sides without any judgment, she started voicing her own reasons to take small steps forward. And this is kind of like that start of her finding her self-agency, where she was starting to start these conversations versus me guiding towards these conversations. And so this is also the start of the beginning of her reframing of her locus of control in her life. So we paired that communication work with graded exposure, which is going to be layering in safe, progressive challenges to help her body and nervous system safely through these experiences. Every small success, from lifting a grocery bag off the floor to taking stairs for the first time in years, became evidence that her system could adapt, and each were celebrated with hugs, high fives, encouragement to keep going. And we reinforced that movement, in this case, wasn't dangerous, but was in fact medicine. Moving down to the end of her plan of care, we eventually got her to feel safe to enter back into the gym atmosphere. And we did this through a combined effort of programming and emphasized the safety and empowerment of safe strength training that was tactful and made for her. And she was able to get to and from the floor and play with her grandchildren eventually, and doing this in their homes. So she also did it fantastic with coming out of some maybe subclinical agoraphobia. So over the months of treating her, and I want to say in recollections, probably about 6 to 7 months I spent with her on a once or twice a week basis, we saw little by little her world was expanding. The storm started to clear. All right, so let's go back and look at how do we maybe measure some of these outcomes or measure this along the way. So far too often, the success in chronic pain has been based on one question: are you still in pain? And when the answer was yes, as often it is, everyone felt like a failure in the room. So the reframe there is, we need to think about what should we ask instead or alongside. And it could be perhaps, what are we able to do now? So we know from the evidence that, again, pain intensity alone is a poor marker of recovery. And what really matters is participation, confidence, and establishing self-agency in this population. So this is why, we might use tools on the day-to-day, such as the patient-specific functional scale, the pain self-efficacy questionnaire, value logs, and other psychological flexibility measures. These capture outcomes that change lives based on the patient's values, and not just less pain, but more life. If you like a little bit more detail on those, you can refer to the handouts. There's a little bit of a description there. So in closing, as we know, pain is a very dynamic process. It's influenced by the brain, the body, the context of our environment, and it's modifiable even when it's still present. So our role isn't necessarily to create these compliant worker bees of patients who just do our bidding and do what we ask them to do in the time of that plan of care, but it's to help people regain agency, confidence, and a sense of life on their terms, bless you, that leads towards the modulation of their pain experience. So as physical therapists, we have an amazing opportunity, as well as the interdisciplinary team in front of me here, to bridge the gap between knowledge and action for these individuals, helping patients carry a story that opens their life rather than closing it. So I'm going to leave everyone with this. In your practice, perhaps what's one phrase that we could change in regard to educating our patients or presenting our findings? And perhaps what's one outcome we might add or utilize that is a bit more values-based versus pain-based? And that's the thread I want to leave us with as we transition to my wonderful colleague Dayle here. I thank you all for your time and attention and the outstanding care you provide to our patients day in and day out.
I'm going to tackle multidisciplinary support and how, after that, can we all come together to really give these patients the best possible care going forward from a multidisciplinary standpoint. I think as PTs, we're in a very unique setting where we get to spend copious amounts of time with these patients that other providers do not get that time with them. That lends to sort of tactics well, but going forward, it's very important that these tactics are woven into every provider's interaction with this patient, because they may hear that from us and not buying it from us, and then they go to these providers and it's the door in their face by one phrase, like your ribs are going to be down on your pelvis. So keeping that in mind as we as we kind of made mention of some of those behavioral and psychological factors. So how are some ways that we can all support behavioral change? Celebrate their functional progressions. They're obviously there, they're in pain. They want you to know about their pain. Don't pretend the pain can resist, we know the pain is there, but they don't need to be asked day in, day out. We don't need to just them waiting for us to suggest a number. At that point, they're just trying to give you something that they think they're looking for. But you can add on functional questions. What's something that you can do today that you could not do the last time I saw you? Or if they mention that they went on a vacation, perhaps you celebrate that. Oh, when you were here last time, you couldn't even walk up the stairs to your house.
That little tactic will, one, give you buy-in because you remember them when they were there before, but it also celebrates now this extra step that they can take. Explore patient-led solutions to any identified barriers. So common, we say, oh, well, you'll just do this. Like, we're their problem solvers. Everyone that's in the medical field is probably a pretty good problem solver. Trying to find ways to help that patient see what the solution might be. You don't know their whole life and background. You only know the 15 minutes that you get with them and what they choose to share with you. So if they tell you that something's a barrier, maybe you can ask them, what is one thing that you could do tomorrow that would be a small step to make a difference on that? Supporting your patients to identify that next step in their goal versus prioritizing the end goal. You can see on this lovely little stair image, this poor sad man on the left, or woman, trying to climb these enormous steps. They're this high, they probably need a ladder or someone to help boost them, and when they look up that step to their big goal, all they see is another huge step in front of them. Everything they're visualizing are these enormous steps that take external support to get to there. When really, maybe they just need one little helper that tells them what this next incremental step is toward that goal, and then they can climb the stairs much more easily in that regard. And then one really important key, this takes a lot of practice. The language is delicate, the interaction with the patient is delicate. No two conversations about pain will ever go the same between this person and the next person you see, or even the same person on multiple days, because there is so much background related to that. So practice ahead of time. Your communication to them is only as good as whatever message they take away from that office visit when they leave. It is not important what you think you said to them. It only matters what they're leaving with and how that impacts them tomorrow when they wake up again. One note that we did in Rehab is we did create a smart phrase similar to this, which I'm happy to share with people, but it is a way that we can start to kind of objectify labeling some of these behaviors, where if I see that in another provider's note that saw them a couple months ago, I can already expect something that I'm gonna make sure I adapt my language to meet them there, instead of trying to figure that out on the first visit. Can everyone read the phrase up there? No? It just says, patient demonstrates psychological and behavioral patterns commonly associated with chronic pain consistent with, and then there's a checkbox scenario, and it just says which may perpetuate symptoms and functional limitations. Now, this is a phrase you may choose to use delicately. There are some patients that read their notes extensively. They will run off and Google these things. But if you are commenting on them, then you should be able to talk to your patient about them in a way that is not like building them up nervous system-wise and anxiety. But for many patients, labeling these factors gives them a way to validate how they've been feeling, and maybe no one else has seen in the last 5 to 10 years of them pursuing medical treatment. Consistency amongst all the providers is key to their functional outcomes that are valuable to the patient. Our EMR gives us endless insights and also a really extensive communication potential that I think is underutilized. We're quite lucky to work in such a huge healthcare system that falls under a single EMR. One provider mentioned those sticky note sensations. I know physical rehab and PT can share the blue stickies, and we can see each other's comments, but sending an in-basket, I very intentionally put things up here that were more related to the patient and their care, rather than lab values, imaging, that sort of thing. We can make a really big difference in patients' care with a warm handoff when you saw a patient and you know they're seeing me next week, which is like a click in the EMR to see, oh, I see you're following up with Dayle next week in PT, and you send me an in-basket or a chat message. Also having some preemptive awareness of socioeconomic factors. HHC has like that little panel in the side pane that does show some of those, but it would be very valuable if in a note you write that they just were at their husband's funeral, or they lost their beloved dog of 15 years. Those things, when they get to their PT appointment, we won't just call out that we're reading this in their note, but it's a way for us to address those conversations knowing that there's something psychologically stressful going on that very much likely impacts their pain. And also the personal touch, the example given before was like someone's dog's name. I started doing that actually after I had a dentist that I hadn't seen in 6 months. And she's like, how was your trip to California? And I was like, how do you know that about people? And she showed me her stickies. In closing, The why for everybody in this room, because we're all healthcare providers, is because we want to help people. And sometimes that caring nature can kind of take over when a patient demonstrates a significant amount of vulnerability. Maybe they start crying, maybe you're the first person to hear them truly, and they just kind of lose it. And in those moments, the caring nature we have will usually take over and say, oh, it's gonna be okay, maybe I'm gonna be the one that helps you through this process. But these patients really, truly need a streamlined approach that helps them have better ownership over their pain and the control factor that comes with that. Us labeling ourselves as like a knight in shining armor coming to help them, long term does not benefit them very much. So I just kind of charge all of you to assess yourselves in, are you being compassionate and hearing your patient and helping them, or are you being intentional while you show compassion? There is a way for you to weave in these motivational interviewing techniques and other things that will encourage the path we want them on and helps them long term with their chronic pain journey than just another person that consoles them and perhaps doesn't actually help them take a step forward towards that bigger goal. We did just put up all the Spine Council member contact information on here, just if anyone has any specific patients, or we're always happy to either case review, talk to people. We'll come to meetings if you want PT's voice at the table. We're happy to do that. References. Questions? Yes. Do you want the PT biased opinion on direct PT?
I am interested in this because we speak about it, on spine council, spine council, spine council. There's so many councils, right?
Yes.
And everyone brings up this concept of direct access. What is everyone's thought on direct physical therapy? Without having, maybe, I don't know if that's a separate from ER or just what's your overall thought process?
I think in general, we are all very biased, and all of us have extra credentials on top of that to be biased towards it. But direct access PT was fought for politically for quite a while through the APTA, and the educational background that clinicians now have compared to, say, 20 years ago when it was a lower level degree, but also had much more of like a paternalistic healthcare environment to interact with, was very different at that time. And the education has risen to a clinical doctorate level to include our ability to assess someone that walks in off the street with a specific injury. Ideally, PTs become the first line of interaction with a patient for any musculoskeletal condition. That can also start to expand into some neuro conditions and things like that. But also part of our education would be the ability to refer to the appropriate provider, which I think sometimes a lot of patients end up in our sessions and people have tried things with them and they have no idea what the next step is, and we're the ones that recommend physiatry or something else. So I think we have special education in that. There's a lot of evidence that patients that are seen earlier in their injury onsets have significantly better outcomes in terms of visits per episode, but also long-term changes. So if we were to evaluate someone that we thought was inappropriate to initiate PT at that time, we would immediately stop care and refer them to a provider that they should be seeing. So I think, do you have anything to add to that?
Yeah, and just in addition to that, like at Harvard Healthcare right now, we do have it where patients with any kind of spine pain, whether it be acute or chronic, they can have a virtual visit with a physical therapist, 7 to 7, basically any day of the week except for Friday, which is 7 to 5, and which just gets them into the system earlier. And sometimes that's just screening and referring referring them to a more medical provider, or it's like initiating exercise or like getting them started into a clinic. And just like Dayle said, we know from the research that it just tends to be less costly, less visits per episode, and patients tend to have a better outcome when they start PT earlier.
Also, one comment, because earlier there was a little bit of back and forth on like research related to telehealth. And at least for PT perspective, there is some newer evidence that suggests that the outcomes are not significantly different in like a virtual only versus a virtual hybrid. through the APTA research. Thank you. We really appreciate staff at this table.
Okay. Lastly, I would like to invite up Dr. Rehab.